Thank you so much, and thank you for joining me today for this, and for many of you who are students, I think. Are some of you students? Who's students? So many of you. I couldn't be happier than to see students. I'm a teacher, and this is a wonderful thing for me, so thank you for coming. I would like to begin by saying so much thanks. I think it's tack så jättemycket to Anna-Stina and Gunnar Höglund. I'm so proud to hold a prize in their name, and this is the greatest honor an educator could imagine in the world, and I'm very, very touched by this. It was a wonderful ceremony last night, and thank you for making it possible for medical educators to be doing the work they do. Karolinska is so famous for so many areas of science and research, and I think for medical education to join at the table with so many other wonderful areas like genetics and neuroscience and really take a place is wonderful. So I'm so grateful. I'd like to recognize an organization in Canada called the AMS, and a project which I've had the pleasure to lead for 5 years called the AMS Phoenix Project. And this is a call to caring. It's a project that is designed to nurture and sustain the learning and practice of compassionate care. And as you heard in the introduction, I will talk a bit about research, but I'd like to talk about the future of where healthcare is going, and start at the end, which is I feel that without holding on to compassion and caring as the reason we're doing this, we should probably go home. Without compassion, I don't think it is healthcare. For those of you in the social media era, perhaps more this morning than last night, I don't know, but I do use Twitter. I like it as a vehicle for scientific discussions, in fact, and so I share articles. Often when I give a keynote, I will use Twitter to circulate the article ahead of time. And so we've had some discussion about these topics on Twitter, and if you use it, I'd be happy to connect with you that way. This is my friend and colleague, Judith John. Judith has had an extraordinary career as a woman who works in the area of communication, a senior leadership in a hospital. She's a wonderful speaker, wonderful person. She also has a benign brain tumor wrapped around her optic nerves. This is also Judith John. This Judith John is the one that is more often attended to in our system. One day she came to the hospital and she was waiting for her doctor, a new doctor she'd not seen, and the doctor came in the room holding the CT scan and looking at the CT scan and never breaking eye contact with the CT scan, walked by her, sat down and said, "Read the top line of the eye chart." Judith said, "I'm sorry, could we just start again? Could you say, 'Hello, I'm Dr. So-and-so,' and I'll say, 'Hello, I'm Judith John. I don't need to be your best friend, but I would like us to have a normal human relationship before we start to talk about what's in my brain.'" And the doctor, to her great credit, stopped and said, "Oh my goodness, you are right. I'm sorry," and introduced herself and made eye contact and made a connection. This story for me illustrates a number of very important points. The first is how often it becomes normal for us in healthcare to talk to an eye chart or an X-ray and not to the patient. The second is the extraordinary optimism of a place where a patient can ask to have a better relationship with a health professional. And the third was a doctor who, probably shocked in a busy day that this happened, nevertheless was skilled enough to recorrect, to stop, and to make a better relationship and build a rapport with the patient. All of these, I think, are really important lessons for us in health professions education about what we need to think about in terms of relations with patients and all of us. So, I'm arguing today that without compassion, without caring, without this component, this human component, we're in big trouble in healthcare. I would argue, and perhaps it's controversial, and when we have questions, maybe you would push back, but All the wonderful technologies and all the advances are fantastic, but it's health care. And so we need to marshal all of those things in some way that creates an environment which is caring and supportive. I love history. Let's look at this quote. For the younger students in the audience, you may even hear this sometimes. So I would prefer the old-fashioned homely care of a good doctor of 40 years ago to that of one of those highly trained, specialized young graduates of today. Yes? That was written in 1937. So perhaps everyone in the audience has encountered this idea. And history teaches me that safeguarding compassion has always been a challenge for us. When I went to medical school in the 80s, and when my teachers went to medical school in the 50s, and when their teachers went to school in the 20s, every generation of health science teacher talks about compassion. But I believe what's happening in our world means that the kind of attention we have given to compassion and care up to this point is not sufficient. I think the number of challenges coming at us from all directions in healthcare means not that our students today have to be as good as we were, as compassionate as we were, as caring as we were. I think they have to be better. I believe that to function effectively and survive today as a health professional, students, the next generation, have to be more equipped, more resilient, and more compassionate than we ever were in my generation. And that's a big challenge for us. So looking forward, to ask the question today, and my research is concerned with, what is the future of healthcare education? And it's a very interesting, exciting, and somewhat daunting future. It's also difficult to predict the future. I'm not a futurist, but I think I can see some important trends. I'm going to start with a rather disturbing trend. This is from an article in 2015 in The Economist magazine from the United Kingdom, from an article called Professor Dr. Robot. And the article says, once regarded as a safe haven, the professions are now in the eye of the storm. Machines are challenging the profession's two most important claims to being special. First, our ability to advance the frontiers of knowledge, and second, the exclusive license of health professionals to apply their expertise to an unordained laity. Now, you feel a little bit of cynicism in this way of speaking, but with the widespread availability of knowledge, with the democratization of knowledge, there's no question that the professional can no longer claim to be the only owner of knowledge and wisdom. Patients don't accept that anymore. But what this points out is that the shift of knowledge and how it's owned and used is changing the way the professions relate and why they exist. And in a place like Karolinska, which is so research intensive, I would also highlight the first point, which is how the rise of artificial intelligence and other things is also changing how we do research, how we create new knowledge and circulate it. So to be very, very simplistic about it, I think there are three spheres that make up competence in any field, and certainly in the health professions. The diagnostic or knowledge-based side, the technical area, or the caring and compassion. And if you're an Aristotelian scholar, you'll recognize episteme, techne, and phronesis. And this is a framework that I think can help us think about what we're doing today and what we're doing in the future. I'm going to look at the first two bubbles briefly, because I think they're important, and then spend lots of time in the bottom. There's no question that this is changing. No question. Most of what I learned in medical school is now incorrect. In fact, there's a saying that 50% of what you learn in medical school will be incorrect 5 years after graduation. The problem is, none of us as teachers know which 50%. I learned all sorts of wild things, like the fact that, ulcers were caused by type A personality disorder. We had a whole week on that. And schizophrenia was caused by the mother, a great tragedy of my field that we blamed mothers for schizophrenia. Many, many things that change with science. So this area is changing. This is in some way our founding mythology. This is the primal scene of medical care, with the caring doctor and the poor child, the weeping mother and the strong father. So there's some stereotypes in here. But this aside, this is to some degree, the way we continue to think of how the knowledge of the doctor is a part of the story, or the nurse, or the physiotherapist. And this gaze, this knowing look at the patient, was something Michel Foucault described in his book, The Birth of the Clinic. The Birth of the Clinic traces the origin of the concept of clinical medicine. But in it, Foucault, Michel Foucault, who was a social theorist, a philosopher, also planted a warning, I believe. And that warning was this medical gaze, this objectifying, neutral, scientific gaze, could, in fact, create the patient as an object of study, a bit like the way we look under the microscope at a patient. And in fact, I think his work has helped me understand how we sometimes drift from diagnosis to objectification, and sometimes from treatment to reductionism. And sometimes in our best attempts to help people, lose the people and focus more on the disease or the x-rays. This is going to intensify. How many people have Siri in your pocket? Siri is with us today. Did you bring Siri or whatever Galaxy and everyone else Google has invented? We all have a little person in our pocket, and that person has not gone to medical school yet. Yet. But if you saw the movie Her, yes, some of you, it's still Scarlett Johansson, still an actress. She's Scandinavian, Johansson, I guess. So she is still an actress. But what the role she's playing of a Siri-like system that asks the poor, lonely guy who lost his job, how are you feeling today? And responds with things like, I notice you didn't go to the gym this morning. Maybe you'd like me to arrange for you to go for dinner or something. We're not very far from that at all. And so the growing ability of artificial intelligence and the machines we are working with is critical for us to understand. It raises something we're going to have to grapple with. I'm not sure at my age if I will. I believe I will, but for the students you will. And that is, you're going to be working with a digital doctor. And it's going to be something like the one in Star Trek, The Next Generation. It's going to be perhaps holographic, but it's going to be a talking form of artificial intelligence that you work with. Because that is where the knowledge is going to be stored. We're no longer going to do what I did, which was memorize 1,000 pages of pharmacology. That is a waste of time. Yes, mechanisms, yes, interpretation, yes, judgment, but the knowledge itself will not be held in the human brain. It's already not held in the human brain. So we are going to be interfacing with forms of artificial intelligence. And so in this area, you can see significant transformations, great opportunities, the ability to triangulate knowledge from all parts of the world instantly. However, we have to ask ourselves, where are the human beings in this story and how will that work? I'll just note in passing that patients will also begin to speak directly to computers themselves. I actually already use YouTube and Google to look up medical problems about myself when I have it. I don't always go to my family doctor to figure out how to solve my repetitive strain injury from too much computer use or whatever problem I have. I do use these systems, and I'm sure you do too. Technical skills. The essence of healthcare is underscored or is strengthened by the physical contact between patients and health professionals. So I'm a psychiatrist, and I have become acutely aware of the need to touch my patients. That's a quote you don't want to take out of context. But I work in intensive care, organ transplant. My patients are confused, delirious. They may come in with a psychiatric disorder, or maybe we give them one while they're in hospital. And it's really, really difficult to be in a place like intensive care where the lights never turn off and the sounds are going all the time. And so for me to stand at the bedside in a kind of sterilized white coat and just talk to the person seems to me to cut off a huge amount of the relationship we need to have. So I always put my hand on a shoulder or a wrist or a hand or something appropriate, but to make a human connection. And if we go back, for students, a lot of your teachers will be nostalgic about the physical exam. Is anyone still quizzing you on whispering pectoraliquy or diaphragmatic excursion, or some, you know, archaic thing from Hippocrates under the tree probably taught these things. And I remember at the time thinking, oh my gosh, why don't we just get an ultrasound or a, you know, a 2D echo or something, really? But what I think gets lost sometimes is that the physical exam, the physical contact is not only about the diagnostic process. It's about the human connection. And the day that Laennec in France invented the stethoscope was a marvelous thing. It was a wonderful way to improve our diagnostic capability. And yet, it put a little space, physical space, between the patient and the doctor. And that space has been getting wider and wider and wider. Many of our tools now are really museum pieces. My father, when I went into medical school, gave me a lance. Do you know what a lance is? The lancet. It's for bloodletting. So there was a time in medical history when part of our common treatment was bloodletting. It wasn't that long ago that we still used the humoral model of disease. So we thought that rebalancing the humors was the way to help people. That persisted quite a while after the evidence was that that wasn't true. But medicine is often slow to take up new advances. So the lance always reminded me that the tools of our trade are also nested in history and time. And the stethoscope, for better or for worse, is almost a historical object now. Almost. And the New York Times did a great article about how the stethoscope is much more status, as a symbol of who we are, than a tool we actually use. As a psychiatrist, I have one. I use it very rarely. I don't never use it, but I use it rarely. And I think this is becoming more common. When my own appendix ruptured in 2010, it was amazing for me to experience the diagnosis being made and communicated by the radiologist. When the emergency physician who had done kind of an abdominal exam several hours earlier came back to explain that the radiology department had called because the CT scan apparently showed, surprise, surprise, that I had a perforated appendix. So that gap is getting quite wide. I never met this radiologist. I had no actual connection. And so for many of you that work in the area of imaging or laboratory sciences, or these things that are so important, I do wonder about the connection that we have that sustains us between the doctor and the patient. Now, technology, just in case you're getting worried that I might be sort of Luddite from the 18th century, railing against technology, I'm not. I really think technology is extremely important, and it's with us. But technology is neutral. Siri is neutral. The CT scanner is neutral. They don't yet have feelings or emotions or morals. So the health professional part of interacting with the technology is essential. So I think what we have to begin to focus on in this area is how we will work together in this environment. This is stereotactic brain surgery. You can appreciate with the increasing precision of machines that if I had a small brain tumor, the error of margin that the machine might be able to create is probably in many cases today less than the human. Last week, Uber signed an accord with the city of Pittsburgh. And in the interview, the president or CEO of Uber was talking about how they plan to replace all the human taxi drivers in Pittsburgh. And the interviewer who's studying this, very interesting idea, the self-driving car is much discussed now, perhaps here as well. And everyone always brings up the fatal Tesla crash, as did this reporter. And the head of Uber said, well, yes, for sure, the self-driving car probably makes mistakes. He said, and you might even consider my attempt to replace all the human drivers in Pittsburgh as a crass capitalist, money grab. As long as it doesn't bother you that human drivers kill 32,000 people every year in the United States. 32,000 people in traffic accidents. And the article is called, When Will We Revoke Humanity's Driver's License? So the case is quite credible for the fact that perhaps human beings should not drive unassisted. 32,000 deaths in the United States pretty much outstrips any medical disease. That's a huge amount of loss. In my country, it's probably about 10% of that because of our size. When will we revoke humanity's ability to manually operate? The Port of Rotterdam today is a busy thing. Port of Rotterdam has been loading and unloading for hundreds of years. A few months ago, the final longshoremen stopped loading anything onto a ship. They retrained to operate the robots. So the longshoremen sit behind big panels of glass and oversee the system that loads and unloads the ships in Rotterdam Harbor. You can go through any number of industries. I took an aircraft across the United States recently, and between the time I arrived at the airport and the time I left the other airport, I saw one person. Who do you think the one person was? What job did that one person have? Just one. The flight attendant. And there was only one, so she seemed pretty busy picking up garbage and cleaning up the area. So I don't know that they found a robot yet to replace her. But the check-in, the baggage check, security, everything all the way between the gate and the airplane was all done by automation. Barcodes and gates and cameras and whatnot. Why do we in healthcare think we're going to be immune to this? We are installing a machine in my hospital that's an automatic dispensary, like a bank machine for your prescriptions, and we have another one that draws blood. So the technologies are advancing quite fast. This is Judith again. This is Judith going into one of her many radiation therapy sessions. This picture was on the cover of our annual report at the hospital, and Judith chose this because they asked her to find an image that would communicate to health professionals, what do patients want? And at first we said, that's the picture you've chosen to talk about what patients want. And she said, yes, because the challenge of the coming years is that when a patient is in a machine, covered with technology, in the operating room, intubated, under a mask, can somebody still look in my eyes? Can somebody still touch me? Can somebody still be there? Because that journey is terrifying. It's important. I think it's fantastic. She gives great credit to the various technologies that have kept her alive. She's doing very well. But that journey is pretty difficult. And so the patients are looking to us as health professionals to be present during that journey. The man who founded the AMS Phoenix Project, who asked me to take on this leadership role, was a cardiovascular thoracic surgeon. Sadly, he died of cancer during the establishment of this process, and I went through the extraordinary experience with him of helping guide a project that was about caring and compassion while he himself was using the health system. And some days he would come to the office. He worked all the way to the very end. Our last meeting, he had oxygen, and he was really working at the end. But he would come some days having had an amazing experience in the hospital or the healthcare system, and he would come other days where he felt, is it all worth it? Are we going anywhere? The day that the doctor breezed in the room and said to his wife, well, more or less, he's going to choke on his own saliva, when she asked how he would die, and left. So Bill told me a story once, because when he was at the end of his life, I interviewed him to ask him, why did a cardiovascular thoracic surgery become interested in compassion? It's an interesting idea. It goes against the stereotype which is very wrong, that professions like psychiatry are the most caring and the surgeons are the least. The person who taught me the most about compassion was a surgeon. But the story he told was when he was a resident in training, and it was night, it was late, and he was receiving the handoff from another resident. And the resident was telling him about this child that was going to the operating room, and my colleague Bill said, well, thank you for all the details about the heart vessels and the surgery, but tell me something about the child's life or family. The other resident said, oh, I don't care about that. And Bill said at that time, he decided if a doctor could ever say, I don't care, he needed to think about a focus for his future. And so all the way to the end of his life, he made the focus the idea that we have to care, that caring is what we're here for. So that's about knowledge, and that's about competence and skills, but now I really want to turn to this area and spend most of our time on caring and compassion, because this is the area where I've spent, I think, most of my time and where my research comes from. So as I mentioned, the AMS Phoenix Project is a Canadian project, similar, for example, to the Gold Foundation in the United States. Many countries have emerging projects to look at how to bolster and sustain caring and compassion. And this involves many, many people, and I would highlight two of my colleagues, Drs. Tina Martimianakis and Rachel Ellaway, who have helped with a categorization of what compassion is. The problem with anything that sounds vague is you can't study it. And the danger with something like caring and compassion is that we call it soft, or we call it on the side. In fact, it's not any of those things. But scientific research is necessary, I believe, sometimes to make something prominent and important. And in their research, which I've drawn from, they talk about compassion as being constructed as several different things. And today we'll look at 4 of those things. Compassion as a behavior, a competence, a value, and perhaps most important in our environments, a resource that can be depleted, a human form of energy, a resource that can be depleted. So let's start with behavior. This is where I've spent so much of my life. I have done a review paper recently about 20-some years of research we've done on this area, which is simulation and education. And this is me with students, and this is a scene you could find often in my life. And in my research, where I have worked to try to think about ways we can use simulation to help people prepare for different scenarios. So in some of my research, we've looked at the use of actors. Sometimes it's real patients with experience. Sometimes it's for teaching. Sometimes for examinations. And we've pushed the limits a lot. In the early days, people told me that simulation was good for a sore knee or to listen to the heart, but you can't possibly simulate Alzheimer's disease or schizophrenia. But in fact, you can. And I think we must. One of the interviewers from the daily newspaper here in Sweden interviewed me on Tuesday or Wednesday and asked me, where did this start? And where it started for me was when I was 16. My grandmother was a nurse. I was very close to my grandmother. She was a old school nurse, you would say. Somebody who worked very, very hard, and at a time she trained, she used to give chloroform, ether. So we're talking about an early history. So she was still practicing. At the very end of her practice, she suggested to me a role which I got at my first job. Well, my second. My first was in a grocery store organizing the cans on the shelf. But when I turned 16, I got a job as a nursing orderly in the hospital. And one of the roles I had in the hospital was something called care after death. So I was trained to do the cardiopulmonary resuscitation. In the hospital, you don't do the breathing part because the anesthesiologist does, but someone has to compress the chest. Seems we haven't got a technology for that yet. I'm not sure. Maybe there is somewhere, but in our hospital, a person did that. So when there was a cardiac arrest, I would come and do the chest compressions. And if the patient should die, the code was called off. Typically, people would leave, and my job was to clean up, remove the intubation, remove the lines, clean up the patient, and in many cases, invite the family in. That was a lot at the age of 16, with no training in any health sciences, really. And I think what I took from that, well, first of all, I took from it an interesting perspective I've always kept with me about what's important in the healthcare journey. But I remember this particular day when I was there and we'd done our heroics and you know, the patient faded and died. And just how the focus got smaller and quieter. And I found myself alone in the room with the person and the mess and the family came in and they looked at me and the wife said, "Why?" You see, I think in healthcare we have to have practiced that scenario. I think, although real life will give us that scenario, I think for a new student or a new practitioner or any of us, those moments are the ones where we have to rise to the occasion and respond. Now, that doesn't mean that I answer with some sort of philosophical answer about the meaning of life. But neither can I become cold or ignore it or turn away or say, oh, my pager's going off, sorry, I have something else to do. In research we did, we found that when a patient is dying, very often the staff avoid the room. They go around. They don't go in. Because they don't know what to do. They don't know what to say. And so my feeling is that as a behavior, we have to learn how to exhibit compassion. Which brings us to as a competence. So far from this being a soft skill or something that's optional or on the side, I think this is a core skill. And far from it being something that it's just kind of nice to have, I think we can assess it. I think if someone doesn't have this, they shouldn't be practicing in the health profession. Do you ever get that false discussion? Maybe it's only North America, but someone sometimes will stand up in one of my talks and say, as a woman did recently, oh, come on. Would you rather have the competent surgeon who knows how to operate but isn't very nice, or the person who's really touchy-feely and nice but doesn't have good technical skills? And my answer is, 6,000 people apply to be in my medical school. I think we can find some people that have technical skills and human compassion. These are not a dichotomy. It's not either or. As I mentioned, the person who taught me the very greatest amount about compassion was a surgeon. So I think that we need to think about this, and a lot of my research has revolved around something, and you can love it or hate it, and sometimes I hate it. I think we've gone a bit crazy with it, but there are many technologies, like OSCE-type exams, and it doesn't have to be an OSCE, it doesn't have to have 10 stations, but what it has to have is an acceptance that each of us needs to have someone watch us do things to see if we can actually do them. That's the logic of this. And I think in our field, if we look back a couple of hundred years ago, it now seems strange to me that you could get your license as a doctor, a nurse, or pharmacist by writing written exams only. Because in fact, the core competence of what we do is what we do. Can we do it? And perhaps we shouldn't go to do it until we can do it. And we should be seen to do it. Interestingly, though, in my more recent research, everything good has another side to it. Maybe the Foucauldian in me thinks about this, but the problem with performing in something like an OSCE or any kind of simulation is its performance. And too much performance can move us away from the real. I found a website. It didn't stay on the web very long, I'll tell you. This blog came down pretty fast, but I swear to you it was there. It was in the United Kingdom, and it was a chat site for medical students, and they were talking about the new requirement for them to write in reflective portfolios. And the blog was called, "They Like It When I Cry." They like it when I cry. They being the faculty. And so I've become interested and somewhat concerned that we be very careful that we not inscribe all this good compassion and relational issues into something very artificial so that we can simply perform it to look like we care. We know that that happens at admissions exams and it happens in very formal types of exams, but it should not be happening in the day-to-day on the ward. We need to know that we have an ability to competently perform caring and compassion and not simply putting on a mask. The sociologists Hannah and Finns have written an article on what they call simulation doctors. And they've argued that if we learn everything about human relations in simulation, the chances are that we will become simulation doctors, that we will only learn to perform or go through the motions of empathy. And I think that's a really interesting thing. Just to complicate it one more, this is the anthropologist Janelle Taylor, who wrote a wonderful paper called "The Moral Aesthetics of Simulated Suffering." You know, your journal title has to be, isn't this a beautiful journal title? What is this about? She studied our world of simulation and found many, many good things, but raised as an anthropologist a concern that we grapple with a little bit more in medicine what it means to be real, what is real, and uses the case of an actor, a woman in the United States, who's playing a simulated patient who is accessing care for a particular disease. And Janelle discovers in the course of her research that this woman in her own real life does not have enough health insurance to actually have the treatment for this actual disease which she has. So the moral aesthetics of simulated suffering is she's playing the role of a patient who's accessing treatment with a doctor who's empathizing with her, but none of it is true. And in her real life, she's not even able to access this treatment. So the question becomes a little bit empathizing with what, and what, in what context, compassion. This is work by my colleague Michelle Spadoni, who's a nurse. And Michelle does, I think, an extraordinary thing in the beginning of the first week of the health sciences course. They do mask making. First of all, if you're claustrophobic, you can't do this because you have to put plaster all over your face and have 2 little holes. But for all the students that can, they make these plaster masks. She points out, not to the students, but in her research, that this tactile and physical connection of working in pairs to make masks is very intimate, and touching someone's face, of course, is one of the most intimate things. So there's an ice-breaking thing. But then she has them paint them. On the outside, they paint what they wish the patients to see about them, and on the inside, they paint what they want to see about themselves or not forget about themselves. And what gets painted on the outside and the inside is a very interesting discussion. But she said what gets painted on the inside in particular contains themes of very personal issues. In this part of our country, many of the students are First Nations, Indigenous. And this is, for some people, difficult because it's a community in our country that lives in a much lower socioeconomic level. People have shared, but privately with themselves, stories of abuse they've been through or people they've lost in their lives. And they talk about how they want to hang on to that, but not necessarily share that with the patient. And I think this is so important because some people misunderstand me as saying that this is all about just opening up your heart and pouring yourself all over the patient, and it is not that at all. It's about coming to know oneself and then figuring out how to translate that through to a stance of caring. A value. We can infer a great deal about the values that are held by people, but also by institutions when we look around. I love this space. Robert and I came a little bit early. We noticed several things. I noticed, for example, little huts in the lobby with tables. They're like little houses. Somebody has understood in architecture the need to have a cozy, there's a Danish word, hygge, which is a kind of a cozy feeling. This is being created as an environment that supports something, which is important for learning. But we have to ask, do our institutions where we provide care to patients actually sustain our compassion or our ability to care? There's many things going on in our institutions. For example, the drive to efficiency, wait times, higher volumes of care. The financial element. And I say this as an executive of a very big hospital, sometimes we confuse valet parking with compassion. Sometimes I hear compassion confused with customer service. And while I think customer service is nice, and I like valet parking, it's great to have someone park my car, that's not quite the same process as helping me with a loved one who's dying or a child who's sick or my fear about being in the healthcare system. We have an enormous hidden curriculum in all of our health sciences schools. What is the hidden curriculum? The hidden curriculum is the thing that's not written down, it's not recorded, it's not on paper, it's not anywhere. The hidden curriculum is what happens after, in my school, you've had 2 years of training in communication skills, 2 years, every Tuesday afternoon. And you've interviewed standardized patients, and you've seen real people, and you've gone on house calls. And then in the first week of your clinical attachment, you come to the emergency department, and there's an elderly patient there, and you're thinking, I'll make some human contact. And the head nurse says to you, wait time strategy, get her out of here. She's already been here for 4 hours, and she's past the limit. That's the hidden curriculum. And so I can't make that go away as an educator. I can't change all of those things. But what I'm becoming increasingly convinced of is that I need to be honest with my students, that they are going to work in that environment. They're going to face these challenges, and it's going to be really hard to sustain compassion when that moment arrives. So this brings me to the final component, and this is that I think most importantly we should attend to the idea that compassion is a resource. It's like a battery. We have a well that we can draw on, and that can be depleted. It can be really drained. We can really run down in terms of compassion. And the environments that we live in, as they become increasingly more technical and sterile, drain us further. It can be very exhausting to work in some of our healthcare environments. Our hospitals and clinics don't all look like this wonderful warm setting with the little houses, and the hygge is not always present in the chemotherapy unit or the surgical suite or even the psychiatric hospital. And most importantly, taking the time to connect with how we feel about things and really recentering ourselves is the most valuable and difficult commodity that we have in the healthcare system. So as a result, literature is showing enormous amounts of burnout, really significant amounts of burnout. Just coming from North America, here's some statistics. 20% of our residents have below average mental health. Half of medical school students experiencing symptoms of burnout while in medical training. Burnout as high as 70% for some health professionals in Canada, fully 60% of nurses having symptoms of burnout in the first 5 years of practice. That, from a health workforce perspective, is a tragedy that's unfolding. And I don't know the answer. If you're thinking, was it always like this? Has it changed? Lifestyle, generations, there's so many factors I don't know. It doesn't matter. The fact that we have a workforce that is often depleted and challenged is really important. And if you put economic analysis on it, as Deewa's work shows, in Canada we lose $213 million every year in sick time and early retirement because of the difficulties sustaining a practice. Now, we all fly a lot, and if you do, you probably see this, or some version of this. The announcement that says, prior to assisting another person, always put on your own oxygen mask first. Okay, so the airlines understand something that we need to learn. Before assisting another person, make sure that your own oxygen level is okay. Sounds like a good idea. I think this extends to caring and compassion. Before trying to care for another person, please make sure that you're okay. And helping each other with that. Because the helping with each other is important. This is not, compassion and caring is not something an individual can do alone. It's not a solo activity. It's a quality that we have to do in the collective. So we have to increasingly emphasize the collective. We have to not just look at patients and say, are you okay? But look at our colleague and say, are you okay? You know, a patient just died. You just resuscitated somebody. Are you all right? Do you need a few minutes? You just delivered a stillborn baby. Do you need to take the afternoon? Or maybe you can't. But if you can't, can I help you maybe think? This is an important set of conversations we need to have. This is why I say that the next generation of health professionals, the students we're training today, those of you that are here, those of us that still have a few years to go, I think it's good for us to focus on increasing our resilience and increasing our capacity to work in an ever more difficult environment. So what is the future of health professions education? Difficult to predict, difficult to predict. I hope it's not this. If it's this, that we cling on to our diagnostic prowess and our knowledge and our skills, our technical skills, but we let caring and compassion slide out of the frame, I actually think we're doomed. I think some combo of artificial intelligence and robotics will make us more or less unnecessary. I think we should cling on to it. I think we need to fill the white coat with a human presence. I'm hoping that the 21st century is characterized by these competencies, by metacognition, ability to think about how we think, honestly think, how we work with artificial intelligence and adapt to that, about practicing, simulating, giving each other feedback in the workplace, not just when we're in school, learning to work as teams, having a shared identity, and of course embracing caring and compassion and human presence, but in an increasing context of human relationships with machines. As Judith John says, this isn't complicated. I don't need you to spend 45 minutes with me doing psychotherapy. I actually just want you to look in my eyes and be present for me. So I hope that my research has contributed a small amount in my work to the sustaining of human presence in healthcare. I think it's the future for us. I hope we retain it. And I want to thank you so very much for your warm attention and for your warm welcome at Karolinska. Mr. Chair, I think there might be time if there are questions. Is that right? Or is it time to go back to the clinic? Yeah. Question? Yeah. Are there any comments or questions you'd like to share? I'd be so happy if a student spoke. Yes. Yes, sir. Yeah. Yes. Okay. And the question is about, what can I do now that I know this? Well, first of all is knowing it. So on rounds, when I do rounds with my team, as I did a few weeks ago, I was in the hospital and I decided one of the things we should talk about is burnout. So I asked the team, do you see burnout? Oh yes. Where do you see it? Interestingly, it's in pockets. They felt there were certain places, certain services, certain environments where it was more common. So I asked the most seniors first. I said, you know, where into medical education as an important area. There's a pair of professors from McGill University who have reviewed the role of mindfulness in medical schools in the world. Several that are taking it up as a really important practice. Some in very simple ways, like in the operating room. My colleague Caroline Moulton studies the role of mindfulness for the surgeon in the operating room and how it can help you to slow down when you should. Keep you centered so that you don't make an error, so that you're aware something's going wrong. You follow your gut instinct. Mindfulness and also situational awareness is a quality that I think people are writing about in terms of good medical practice and safety. So that's fantastic, and perhaps if you feel comfortable and have a way to share it with your colleagues, I think that for people to understand that practice and that orientation would be very helpful for many people. Yeah. Other questions or thoughts about anything you've heard today? Usually someone jumps in on artificial intelligence somewhere. Yes?
Are there any evidences that you can maybe decrease amounts of burnouts by just educating people working with healthcare more in professional learning and that you in the actual environment later in the clinics also facilitate for these people to practice more about what they have learned about in professional learning?
Yes, there is. The question is there evidence about strategies that reduce burnout in the clinical learning environment? And I would say the number one is it comes from a theory called stress inoculation. Has anyone heard of stress inoculation? If you're a psychologist, perhaps you're familiar. So in fields that are highly stressful, like military, or where really difficult or traumatic things have to be handled, stress inoculation is almost the same idea as a vaccination. And that's where simulation comes to play. So, for example, if we could simulate an environment in which a very difficult thing happens, the evidence is that that will create greater resilience when the actual thing happens. This is why people do mock disasters, for example. So I'm quite interested in this now, and I think this is an emerging technology. In our research, one simulation we've often done is the angry person. I find one of the hardest things to handle is an angry patient. Sad, distressed, fearful, those are difficult, but angry is very difficult because your immediate human response is to become angry back, and that's not helpful. So things that are going to happen in the environment with their consent and with their practice and with careful escalation and debriefing. But this idea of inoculating people or exposing them in a controlled and safe environment to something that's very, very difficult, there's very good evidence that this reduces this. The airlines have known this forever. Do you recall the Air France plane? Maybe you don't because it was in Toronto, but the big one, 340, the Airbus 340, ran off the runway in Toronto and went into a ravine. and the plane caught fire. But they managed to evacuate the entire passenger component, which I think was 290 people, or some enormous number of people, in 90 seconds. And so when I work in France, I have a connection with the University of Paris, and so I have a colleague who works with them, what is the training that you do for that? Because that's actually extraordinary. I don't think I could evacuate my house in 90 seconds, let alone 250 people from a plane. And what they do is they train them in some basic, they're all in a field and then the plane catches fire and it's a good story. But I think that that's not intuitive, right? That's not intuitive. And so the tendency, if there's been a plane crashing, is that the flight attendants must panic. They must get very anxious. There's nothing superhuman about the flight crew. There's nothing superhuman about the surgeon or the nurse in the operating room when the patient starts exsanguinating all over the operating room. There's nothing superhuman. But we need to have practice to strategy. So I think stress inoculation and practice is a big, big part, and it is evidence-based. Yes?
Thank you for being here. And then when I saw your picture about the different competencies, diagnosis, technical diagnostic skills, technical skills, and then care and compassion, I thought of the Aristotelian concept of phronesis.
Yes. Phronesis. Thank you for this question. Whenever one gives a talk, there's always a balance between the deeply philosophical and research base that we have and creating a clear message. So this is actually the Aristotelian framework, but with some modification. So what our colleague is asking about is, in Aristotle's thinking, the bottom circle is called phronesis, which is a sort of practical wisdom, a way of interacting with the world. I do agree with that, and it's a nice critique too, and I accept it if that's how you see it. Caring and compassion is not the only component of this ability to integrate complexity and understand the world. It's absolutely true. So for example, I think if we had more time to talk about how we will survive in the computer age, the idea of wisdom, of judgment, of practical knowledge is going to be something that the human will have to portray. And I do think that in the diagram we could actually spend a lot of time blowing up what's in there. It's funny they were going back to Aristotle, a theorist from 2,000 years ago, to find a competence framework. But I take a lot from it. And reading about this, phronesis, P-H-R-O-N-E-S-I-S, is this concept. And for us in education, this is a very valuable research area to look at in terms of understanding what's wrong with only looking at knowledge and skills. And the what's wrong with that, as I've alluded to, I think, is that those things will be replaced over time by different systems that are able to do it. I like to think in my lifetime the human being will never totally be replaced. I don't know about the 22nd or 23rd century, but in the 21st century, I think the role for the human to do that role is really important. The Americans have just had a conference called, "Does the Doctor Need to Be a Human?" Yeah, seriously. And so that problem, which seemed strange and esoteric a few years ago, is now pressing as a real problem. And perhaps, I'd be interested to hear if you agree or not, but perhaps the most human of all qualities is phronesis. What do you think?
If you take back your picture.
You want to go back to the picture?
Yeah. The way I perceive.
This one?
Yeah. The middle.
Oh, the middle.
Oh, this is phronesis.
Oh, you see phronesis here. Yeah, that's
No, in the middle.
in the middle, yeah, this.
You need the diagnostic
This,
skills,
yeah, yeah.
technical
It integrates.
caring and compassion.
I like that. I like that very much. Can I get your name after and I'll give you credit for a new slide? No, I do. I think there is some synthetic concept that is required there. That's interesting you see it there. Practical wisdom requires these things. Yeah, I like that. Thank you. I knew that I would learn more at Karolinska than I would ever bring. Mindful of the time, it's 1 o'clock, and I think probably many of you have other things, including clinics and classrooms, to go to. So perhaps, if it's okay, we should officially end, but I would be more than happy to stay if there are other questions or points that people would like to raise.